As we all know, the past months have presented an unprecedented challenge within healthcare in general and within post-acute healthcare in particular. And we've all struggled to figure out how do we deal with the issues, and we certainly thank all the people around the country that have provided so much expertise, one of which is our own Dr. James Avery, who's back with us today. He's provided so much great counsel over the past few months for us. The question now is, we have seen news reports that keep referring to the fact that the country is now reemerging. Announcements, proclamations made that say the country is now open for business. We think about that from the healthcare world. What does that really mean for us? And what does that mean for us that are responsible for delivering post-acute healthcare? What are some of the variables that we need to consider? And will the circumstances be the same in all settings and in all parts of the country? So to respond to those questions, we've asked Dr. Avery to come back again and chat with us about his thoughts about this. Dr. Avery is a nationally recognized pulmonologist with specialized expertise in long-term care settings, home health care, and hospice care. He currently is the National Medical Director at Diversicare Healthcare Services and is also a visiting professor of medicine at the University of Virginia School of Medicine. And with that, Dr. Avery, I'm going to turn it over to you.
Hey, thanks, Mark. Thanks, Hal. And let's go to the next slide. So America's open for business. And what does that mean for facility operators? It means a lot. But before we jump in, just a quick word. You know, people have strong opinions about COVID-19, strong opinions on the political spectrum and in the operational world. This lecture is designed to help separate fact from opinion so you can have a fuller understanding. You can make wise choices for your residents, for your patients, and for your staff. And on the next slide, I have a disclaimer. It's important to know that this is a changing field. You know, we get new information continually. So it's important that each of you monitor CDC, CMS updates. The information today is the most up-to-date. It could change next week. And these views don't necessarily express the views of Aegis Therapies. Okay, next slide, please. And just my medical background, Hal talked about it, so let's jump right in just to say on the next slide that I'm internal medicine, pulmonary, and long time in nursing homes and long-term care. We're going to talk about what we have learned so far, bring you up to date since the last lecture. We're going to be talking about the 3 phases, the CDC, and how do we open up America? And then are you personally ready? And then possibly the most revolutionary section, the culture change. What type of culture change do you have to do at your center to make this work? Okay, let's jump into the first section. What have we learned? And we have learned a lot. Let's go to the next slide. An interesting fact, this virus has brought the entire Earth to its knees in a way. How big is this virus? Next slide. And what you'll see here is that you can actually fit 20 million COVID-19 viruses on the tip of a human hair. This small little virus has caused those kind of problems, but it tells you the size. On the next slide, now, how does this thing get into us? How does it cause infections? This is a reminder, it's the nose, the mouth, and the eyes. Mainly the nose and the mouth. Now, of course, you can go hands to nose, hands to mouth, hands to eyes. I guess you can go foot to nose, foot to mouth, foot to eyes, but it has to get in through 3 doors mainly, the nose and the mouth, and maybe the eyes, less often. Okay, so how many viruses does it take to cause an infection? The most recent studies show it takes a couple thousand viruses. Some experts say maybe as few as 1,000 is what it takes. You can get exposed to much less, no problem. More, and the more the exposure, the more severe the infection. So let's talk about how does it, on the next slide, how does it get into our nose, our mouth, and our eyes? Basically, there's something called large infectious droplets. And we're going to go into this in more detail. This is just the first blush. These are heavy and wet, and they fall quickly. They only travel maybe 1 to 3 feet. They're small infectious droplets. They're small and wet, and they fall slower and maybe travel 3 to 5 feet. That's where the 6 feet rule comes in. There's aerosolized droplets. Now, those are the virus is suspended in liquid particles and it becomes an invisible like cloud suspended in air. This can travel 10 to 20 feet and hang in the air for 30 to 90 minutes. And some infections, some not coronavirus, some like tuberculosis can go in infectious droplet nuclei. These are dry and they can hang in the air for hours and hours, and they can go, 300 feet as far as a football field. But for coronavirus, it's only the first three. Okay, let's look at the next slide. Let's make this a visual. You look at the visual, you can see the large droplets, 1 to 3 feet, the small ones, 3 to 5 feet. And again, infectious droplet nuclei, that's only tuberculosis, measles, a couple other things, but not coronavirus. The aerosolized droplets, which again are uncommon, those are 10 to 20 feet, and they hang around for about an hour. Okay, what's the magic formula on the next slide for getting infected? It's the amount of virus. Remember, you need at least 1,000 plus the time you're exposed to it. That's your likelihood of getting infected. Okay, let's look at some specifics. Let's make this formula real so you can actually feel what I'm talking about. Next slide, please.
See, there still needs to be an impressive and strong movement.
To make it, that's the point there that all of that activism goes hand in hand.
I think somebody needs to mute their phone. Can somebody mute their phone, please? Thank you. I think we're getting some background noise. Okay, so we gave the magical formula: amount of virus times time equals the likelihood. The worst thing is a sneeze. 30,000 droplets. Droplets travel 200 miles an hour. They're small, easily cross a room and into the hallway. I'm thinking now of a nursing home. Next slide, a cough, not quite as bad. Now we've gone from 30,000 droplets to 3,000, and we've gone from 200 miles an hour to 50. They're large. They're the wet ones that we talked about earlier. They stay in the air, but they don't travel very far, but they can go across a room. Okay, next, how about speaking and talking? This is only 200 viruses. Remember, the sneeze, 30,000. A cough, 3,000. Speaking, only 200 viruses per minute. And so if you're in the same room as somebody and assume you inhale 1/3 of them, it would take 15 minutes for you to get the required, remember, 1,000 viruses. So anytime you spend greater than 10 minutes in a face-to-face conversation, this is without a mask, of course, you can get infected. And that's where the old term prolonged close contact. If you remember the original studies, we talked about prolonged close contact. We're not doing that anymore. This is it. Next slide. Now, how about if you're just in a room and nobody's speaking, nobody's talking, people are just breathing? That releases about 50 droplets per minute. And most of these are very low velocity. For example, when somebody speaks loudly, it goes further, falls to the ground. But with these, it falls to the ground quickly because they're low velocity, they fall down. Now, we don't have a number for COVID-19 yet on just breathing, but studies show that a person infected with influenza, they'll release about 1,000 particles per hour. So if you have to inhale 1,000 viral particles, you'd have to be in the same confined room and breathe almost their same air for hours. Let's look at a practical example. So on this slide, the yellow A1, this is a restaurant, okay? A 5-table restaurant. And what you can see is table A has A1. A1 is the person who is asymptomatic and was having dinner. Their dinner lasted about 3 hours. And what we see is the air conditioner is on the right side of this room, and the air flows one direction, and there's an exhaust fan, I don't know if you can see that, between B and D on the other side. Okay, so the air is flowing that way. A1 is infected, nobody else is infected, and they're having dinner. Their dinner lasted, it was a long dinner, it lasted somewhere around 3 hours. This was a long dinner, okay? And notice around A's table, the people right across got infected. One guy 3 days later, another person 5 days later, a couple on the other side, but 3 out of 4 people on table B got infected because the airflow tended to go that way. It's going to go against the air conditioner, of course, when he's speaking, but it's or talking to somebody, but it goes the other way. But notice tables E and F. Nobody got infected. So airflow becomes really important because now you're getting the picture. There is these droplets, and there's, and then you can go against airflow if you sneeze because it's such a violent, rapid thing. Let's go to the next slide. This is an office, a building, actually a call center, and everybody's in a cubicle. The blue spots are people who are infected. They never knew who was the one who started it. But notice on the same floor, on the opposite side of the building, nobody gets infected. And so what we see here was the airflow that spread it throughout, and people are in that room for 8 hours making phone calls, only protected by a cubicle. So just speaking into a phone, maybe speaking loudly, you suddenly have these particles that are going around. Next slide. I want to tell you one story. This is a guy named Bob, not his real name. He's in Chicago. Now, he was infected. He was asymptomatic, but he didn't know it. So he went to a place. They had a takeout meal. They had common dishes, and with 2 family members. A long dinner again. I don't know why all these dinners are lasting about 3 hours. Within 4 days, both family members got sick, and they shared the same dishes. They shared the same plates. So nobody knows within 4 days. But Bob is still not sick. He attended a birthday party that had 9 people. They hugged each other. They shared food. They had a common food area on the table. 7 out of the 9 got sick. Now, 3 of the people he infected at the birthday party went to church, getting, at least based on the researchers, 4 members of that church sick. In all, Bob was responsible for infecting 16 people between the ages of 5 and 86, and 3 of them died. So now we're getting a picture for the infection. Let's go to the next slide. So what we're seeing, the magic formula, the amount of virus one is exposed to times the time you're exposed gives you the likelihood of getting infected. Notice how much more sophisticated this was than the 6-foot rule, the social distancing rule, which really was intended for brief encounters, meaning you're going into, a store and the cashier is there. Those kind of things. Social distancing was the key there. But now we understand this better. So let's get some take-home messages first. Next slide. We're going to go to a timeline first. I want to show you again. Remember, typically people, day 0, the red, is the onset of symptoms. 4 days before is 4 to 5 days people get exposed. 4 or 5 days later, you get sick. 2 days before you get sick, your PCR, the nasopharyngeal swab, is positive. 5 days after the onset, your body starts kicking in antibodies. And suddenly the amount of virus on those nasopharyngeal swabs starts to go down. By day 7, often the PCR test, the nasopharyngeal test, is negative. It can still be positive for a much longer period, but in most people, it's starting to cut down. And then by 14 to 30 days, your IgG antibodies are appearing, and those are the ones that give you immunity. So we have a time frame for this. Okay, next. So the key points from this time frame, 50% of people have no symptoms, asymptomatic. It's over 50. On one cruise ship, 81% of the people are asymptomatic. The incubation period is 4 to 5 days from exposure to start of symptoms. It can be as long as 14 days, but on average, 4 to 5 days. And you saw that if you looked at that the dining table, the one that I gave you. People are most infectious a day or two before they know they even have it. And again, the PCR test turns positive. And by day 10, most people are no longer contagious. You can be contagious for longer periods if you had a really severe infection or if you have a weak immune system. All right, so what's the take home from all of this stuff on the next slide? What we find is that it spreads best when people are indoors in crowded settings with poor ventilation for a prolonged period of time. Let me repeat that. You don't have, it's worse, it spreads best when you're indoors in a crowded setting and the air's not moving for a prolonged period of time. Okay, next slide. Now, what I have found in the nursing home setting, we have 60 plus nursing homes, and the anecdotal stories from lots of chief medical officers, is that the most likely origin of a nursing home infection is your staff. Second most common, new admissions. Third most common, therapy staff. All right, let's go through some really practical things to cement this in. Next slide. So is this high risk or low risk? You're walking along the sidewalk and you walk right by somebody. High risk or low risk? Notice nobody has a mask on. Next slide. Remember, it's dose and time. You need viral particles and you need time. You would have to be in the airstream of somebody for 10 to 15 minutes to get infected. I mean, we still want you to keep your distance, but the risk is very low in that scenario. Okay, next slide. So now you're going grocery shopping. High risk or low risk? Now, I'm going to discuss risk not based on, if you touch the avocados and someone else just sneezed on them and you touch your mouth, well, there you go. I'm going to be talking about just in the air, assuming you wash your hands, assuming you don't touch your nose, your mouth, or your eyes. Is this high risk or low risk? Next. It's actually low risk. Why? There's a lot of air at a grocery store, right? The number of people was relatively small. And you don't spend a whole lot of time with any particular person in a grocery store, maybe an hour or less. So low density of people, high volume, restricted time, the odds are very low. I wouldn't say very low, I'll put low risk. All right, next slide. What if you're in a crowded office? I can tell you, we've done, our company has done over 3,000 tests. And we have a lot of little offices in our company, in our nursing homes, 2 or 3 people in a pretty crowded, small office. We have found when one person in that office gets it, all 3 of them get it. So if you're sitting in a small office with other people, you don't have mask on, you're breathing, you're talking, you're on the phone, maybe sharing a phone, that's going to be what? Next slide. That's going to be high risk. Because you have a small volume of air. You have a relatively large number of people who are talking, breathing, maybe even sharing the same phone. That's going to be a high risk situation. And again, we're assuming no mask. Okay, next slide. So what have we learned? Wear the proper PPE at work. Avoid crowds. Avoid indoor spaces with poor ventilation. Keep your distance from others or limit the time. Wear a face mask in public or in meetings. Wash your hands a lot. I mean, a lot. And before and after meals, after you open up the mail, after you open up a delivery package. Finally, don't touch your nose, your mouth, or your eyes. But next slide. But is it that draconian? Couple things. But go outside, get fresh air. The effects of sunlight, heat, and humidity all reduce viral survival. In fact, as it gets hotter and more humid, air gets heavier and droplets fall to the ground quicker. Small droplets become heavier droplets. Large droplets become even heavier. Aerosolized clouds fall to the ground quicker. So take walks, jog, garden, ride your bicycle. And by the way, don't yell at the jogger who isn't wearing a mask, or the beach goer who's not wearing a mask, or the person having a picnic in the park. You're not going to get infected from them. That's the kind of things you want to do and you should do. All right. Hopefully we brought you up to date now on how this thing gets around, how it gets infected, and how you can protect yourself. Now teach this to your staff, because remember, number one person who can go get it, your staff is going to bring the virus into your center. All right, let's talk about opening up America and the 3 phases. Next slide. The CDC has established 3 phases, and these are based on 6 criteria. They're looking at the number of new COVID-19 cases, emergency room visits, outpatient visits, whether it's the number of positive tests, the ability to treat all people, in other words, how many hospital beds are in a certain community, how's the PPE levels, and do we have enough test kits? Can we do robust testing? Can we do tests all 100 people in your nursing home? That's how the CDC has developed their phases. So when you hear phase 1, phase 2, phase 3. Now don't confuse that with your state. Some states have 5 phases, some states have 6 phases, some have 3. The CDC has their own phases. Okay, next. Now, opening up nursing homes, according to the CDC, will be based on your status in your nursing home. What's going on at the bedside? What's going on in your community? What's going on in your state? And remember, nursing centers will not be in the same phase as their community or their state. In fact, there's no phase that you'll be giving to your center. You are the ones that need to determine that, because you know best what's happening there. So next slide. So phase 1 from the CDC is what we're currently doing, all the strict criteria. Phase 2, really nothing changes. You're not going to have visitors coming in, nothing else, but you are going to have an increase in survey activity based on certain priorities. I'm going to give you those priorities on the next slide, but I'm not going to go there yet. Those are key. Remember, you're going to get this slideshow. You need to know. They're telling us who are they going to be checking on. And when the CDC and CMS tells you we are going to focus on you, you want to know which of your facilities is going to get, the white glove treatment. And believe me, it will be white glove. Phase 3 is when visitors are allowed with screening, non-essential visitors are redefined, volunteers are allowed, normal survey operations will resume. The surveys in phase 2 are infection control surveys. The surveys in phase 3, back to the annual complaint and standard surveys. Even in phase 3, though, there still will be 100% screening, weekly testing of staff, universal mask, and dedicated spaces. Okay, next slide. Now this is the stuff you need to know. State surveyors will be prioritizing these phase 2 surveys. If you've had COVID-19 positive cases, count on it. They will be there when you go into phase 2. If you're a special focus facility, if you're a special focus candidate, and if you've been overdue for a standard survey, or you have a history of non-compliance in the last couple years, be prepared. They will be knocking on the door. Now, they will also be prioritizing complaint surveys. As always, abuse and neglect are number 1. Infection control is second. They want to look for transfer or discharge requirements. Are you following the infection control criteria? Insufficient staffing, and finally, quality of care issues. So just be aware, they are telling you who is going to go under the microscope. Okay, next slide. So we've talked about the CDC, but the question is, are you ready? Is your nursing home, is your center, is your facility ready? Next slide. Now, we had Captain America on the first slide of this presentation. This is not superhero stuff. It's the people who will do well in the next few months, or maybe probably next year, are those who do the basics well and consistently. So let's go into some specifics. So I want to help you to thrive and succeed. You want to evaluate your risk constantly. So as America opens up, there's going to be pressure on you to open up. And there's going to be more cases in your community. That's a bad combination, right? You're having pressure put on you by family, by staff, by residents. At the same time, more cases in the community because people are getting out more. People are going back to work. So we need to look at our situations and make judgments. Now you know it's how many people, what's the airflow, how long will we be in this environment. Let me give you an example. So you're going to have to evaluate your risk. So a local pizza place donates pizza to your nursing home, and you have a very small break room. And the pizza was placed, the 6 or 7 boxes were placed in that room. What do you do? Now, the reason I bring this up is one of the worst outbreaks that I've heard about was caused by donated free pizza. What happened? It was put in this exact setting in a small break room. Everybody in the break comes in while the pizza's hot, right? Everybody comes in, they take off their mask. They're eating the pizza. They're talking. They're in a small room. And a major outbreak occurred. Team members within 4 or 5 days, some asymptomatic, some started getting sick. Next thing you know, a patient went to the hospital. They get tested, they're positive. Almost every single employee of that shift in that nursing home was infected. It all started with an asymptomatic person and a pizza party. But remember, you know the risk now. Small room, air not moving, everybody talking, sharing food. Perfect scenario. So you have to be on your guard and evaluate your risk. Next slide. I like to call this, you need to have situational awareness. Know what is happening in your center, in your community, in your state. Stay up to date on the CDC and CMS websites. I congratulate you for coming on this lecture. Because of Aegis providing this, you can learn stuff now so you can protect yourself by having more knowledge. Next slide. So I just threw this slide in because I sort of liked it. These are 2 divers, and if you're getting a good visual here, that is a huge shark right behind them. Situational awareness is that important. You have to be aware of what is happening. Let's go to the next slide. So one way to have situational awareness is this testing. And right now for staff, you need to make sure you're having baseline testing and weekly testing of negative staff. Residents need baseline testing, of course, and testing if any negative residents if new cases appear. By the way, once a person, staff member, or resident is positive, they don't need to get tested again, right? And some may stay persistently positive. You only keep on testing negative ones. So you need to keep good records of every staff member, when they were tested, what the results were. For training, you need to continually train on the proper use of PPE, hand hygiene, cough etiquette, social distancing. Use the pizza party example. Give them this lecture. You will have access to it. Establish schedules for training and records. Establish schedules and training for testing. It's critical as you go forward. On the next slide. Now, I've given you some information here on how it works for testing. I'm not going to go through this here, but just to say you're going to have access to the slides. And by looking at the slide, you can actually tell where a person is. For example, the blue line is the virus. The green line, or I think it's green, is the IgM. Goes up and down, and the IgG comes latest. So for example, we had a recent test done. One of our staff members' husbands was positive. She came in and she was negative.